topic about ESWL, nephrology and perspectives. First of all, ESWL is standing for extracorporeal shock wave lithotripsy, we all know that, used for the treatment of renal stones, which are pretty frequent. We have a lifetime risk of stone formation of about 5 to 10%, increasing in cases of recurrence to 50% at 5 years and 80 to 90% at 10 years. The market of ESWL is huge. It's growing rapidly. We're having China, the biggest market country, and it's all over the world, with mainly in Africa, Egypt being the biggest market for ESWL machines. The history of renal stones, of course, one of the earliest recorded renal stones was found in Egyptian mummy. And until the 19th century, bladder stones were removed via the perineum without anesthesia. This picture shows 3 individuals stabilizing a patient to be able to remove the bladder stone, and of course it was a very high risky procedure with high risks of bleeding or infection. The earliest written references to stone surgery was from Hippocrates in 400 before Jesus Christ, and he said, "I will not cut for stones, even for the patient in whom the disease is manifest. I will leave this operation to be performed by the practitioners." And actually, this is what civilization and scientific developments was targeting at, not cutting for stones, and this is what ESWL actually made us realize. It was first introduced by Claude Dornier, who wasn't a physician, who was actually a scientist, using some specific devices for airspace parts, and the technology discovered was used for the ESWL machine. How the ESWL machines works? By causing micro cracks that progressively lengthen and expand until failure occurs. The mechanisms include direct stress, but also something called cavitation, which is formation of bubbles in urine, creating powerful secondary shock waves, causing fluid microjets directed at the surface of the stone. While all of these different options used for stone removal, ESWL and ureteroscopy, are actually 90% of the different procedures used for stone removal. And at the beginning, it was so magical that virtually any type of stone in any place in the kidney where we could use ESWL to remove it. And it was seen as a safe procedure without severe acute or long-term adverse effects. But the picture is not as perfect. It was discovered that actually the success rates of ESWL could range from 46% to 91%. Why? Why should it fail? I mean, actually, the procedure just breaks down the kidney stones into very small pieces, which usually passes through the urinary tract. And this happens, especially the fragments are 4 to 5 millimeters, and the only problem happening then is only the pain associated with the excretion of the fragments. Yet, we could have incomplete stone fragmentation, and the biggest fear is Steinstrasse, which is stone street, which is a pileup of a large number of unpassable stone fragments obstructing the ureter and causing actually a mass of stone debris higher than the ureter capacity to excrete it. It occurs in 1 to 4% of patients, increasing up to 10% for big stones bigger than 2 centimeters, and up to 40% of patients in patients with partial staghorn calculi. So the composition of stones is very important when we plan for ESWL therapy. Actually, if it's a stovite, uric acid, or calcium oxalate, usually it's an easy procedure for ESWL to get rid of them. In cases of calcium phosphate and monohydrate calcium oxalate, it's harder, and the hardest one of all are the cystine stones. When ESWL fails, we have an unnecessary exposure of the renal parenchyma to the shock waves. It leads to complications and further alternative treatments and additional medical expenses. So we use ESWL when you have a symptomatic renal and ureteral stone. It's not indicated for asymptomatic small stones, and it's most effective for stones in the renal pelvis and the upper ureter, while it's much less effective if you have stones in complex renal or ureteral locations, which are the lower pole of the kidney or the lower and middle ureters. Also less effective, as I mentioned, in bigger stones or in stones of harder composition like calcium oxalate and cystine stones. And because of that, many kind of articles started tailoring the treatment. And we have contraindications such as, of course, pregnancy, uncontrolled infections, uncontrolled alterations in coagulation, aortic or renal artery aneurysm, serious skeletal malformations for difficulty in positioning of the patient during the procedure, and serious obesity also, making the ultrasounds waves reaching more difficulty to the stones and being less effective. Despite all of this tailoring of treatment, still complications are happening. Well, we are trying to focus the waves on the renal calyceal system, yet it can include injury to surrounding organs as well. These are not very common, but these are mentioned. All of these different complications were mentioned following ESWL procedures. But ESWL mainly causes nephrological complications. What are they? Do you remember the cavitation that we mentioned? The procedure where we had urinary bubbles on the stones? Well, actually the cavitation was found to cause dramatic vascular insults in which the capillaries, veins, and medium to small diameter arteries are torn, causing focal sites of parenchymal and subcapsular hemorrhage, tubular and glomerular damage, and we have infiltration of inflammatory cells with the cascade of events leading to scar formation. Well, the study said, well, it's not a big deal because after the ESWL procedure, when you do an ultrasound, the percentage of hematomas or fluid is only 1%. Well, when they started actually doing systematically CT or MRI, the evidence of hematoma rises to 25%. X-rays, it was found that there is an increase in the volume of the kidneys. And the sonar, there was a loss in corticomedullary demarcations and a reduction in the signal of the perirenal fat, denoting that there are lesions such as hemorrhages, but which are focalized, and edema within and around the kidney after ESWL procedures. And it was also found that the higher the energy the patient was exposed to, the higher the risk of hematomas and the risk of hemorrhages. And in animal studies, a typical clinical dose of the Dornier HM3 lithotripsir produces a parenchymal lesion measuring 5 to 6% of the functional renal volume. Cavitation was also found to allow the passage of bacteria into the bloodstream, causing potentially bacteremia and septicemia. And that's why it was an absolute contraindication to do ESWL if you have complicated infections, and often they give prophylactic antibiotics before the procedure. There are other complications which have been suggested following ESWL: hypertension, diminished GFR and CKD, acute kidney injury, transformation of stone disease, and even diabetes mellitus. How come? Regarding hypertension, actually the data for hypertension are the most compelling of all these different diseases. A number of studies have evaluated the development of new onset hypertension and follow-up periods ranging from 90 days to 19 years, and still the data are conflicting. In this paper, it was a report on 578 patients who had done ESWL, and the follow-up was 19 years, and hypertension was significantly more prevalent in the ESWL group. In this population-based retrospective study of 11,000 patients, which compared what happened to these patients who did urolithiasis, including ESWL and also ureteroscopy, and they excluded totally any patient with hypertension or CKD. What they found, that during the procedures in general, causes a significant hazard ratio for hypertension. ESWL was associated with a significant increased risk of hypertension, while actually ureteroscopy was not. And when further stratified, ESWL to the kidney or the ureter, where they found that ESWL to the kidney was significantly and independently associated with hypertension. In this paper, they also found that in particular, there is diastolic hypertension in these patients, and there is a relationship between, again, this and the number of shock waves. Therefore, it was a hypothesis presented. But on the other side, in this paper, where they reported a percentage of only 8% of cases, they found that, well, it doesn't really differ greatly from the incidence of about 6% found in the overall population. The mechanisms which were proposed regarding hypertension development in ESWL were due to maybe something associated with in the patient. Like, for example, we have altered nephron physiology in renal calculi and hypertension. We have a higher sodium intake in patients with renal calculi and hypertension, and also we have increased prevalence of metabolic syndrome, gout, or CKD. But again, could as well cause hypertension? That's a question that we have to answer still. Regarding diminished GFR or CKD, well, we have mentioned all these different experimental animal studies showing clearly that as well trauma was regarded to cause scar formation and loss of functional renal mass. The possible mechanisms also could be due to a direct effect or the associations present in these cases. But other recent studies said that, well, renal function is largely resolved within 1 to 3 months after it was found that it was delayed. And it has no significant long-term effects on renal functions. But again, these were small cohorts of fewer than several hundred patients with short follow-up times. There is even a study where they took 65 patients with solitary kidney who did as well, and they found a lack of deterioration of GFR. And there is even further, there is this study which proved or which suggested that as well actually delays progression of chronic kidney disease in cases where we have actually CKD, stage 3 and stage 4, and they followed up these cases for 3.2 years, and the different findings suggested that actually stone removal by as well is associated with a delayed deterioration of renal function in CKD patients. And they say that maybe the short-term harmful effects of as well waned over time, while the long-term positive effect from stone clearance is actually what persisted. The mechanism could be that maybe the removal of the kidney stones improves the urine flow and decreases repeated short-lived bouts of partial obstructive nephropathy caused by the stones. What about acute kidney injury? Well, urologists, they know very well that a perinephric hematoma can lead to a modest yet reversible elevation in serum creatinine. And yet, on the other side, there are these case studies which describe a variety of severe complications, including irreversible acute renal failure. And it even was interesting that this happened in the absence of excessive bleeding. And this is another patient who wasn't as lucky with a solitary kidney with irreversible acute renal failure following the ASWEL procedure. Regarding these two, transformation of stone disease and diabetes mellitus, well, the data are not really kind of validated and they are new, but it is suggested that actually there is transformation of the type of stone diseases, that there is a higher percentage of calcium phosphate stones if patient did several lithotripsy sessions. It is suggested that these patients, usually when they have calcium oxalate disease, which is the most common type of stones met, and actually they do transform to bruchite disease due to the fact that there may be as well cause a progressive injury in the renal papillae, which could alter the normal physiology of the collecting ducts. And of course, the bruchite stones are much more difficult to treat and do not respond well to the ASWEL. Diabetes, in this paper, where they studied and did a follow-up of 19 years of these patients, they found that 16.8% of these patients can develop diabetes. And they also found that it was related to the number of ASWEL sessions in each patient. But again, the authors were duly cautious in their approach, and subsequent reports noted a number of limitations to this study. Another one was very smart in trying to explain this, saying that actually the majority of the cells, of the beta cells, are in the head of the pancreas, and they related the site of the ASWEL to the possibility of developing diabetes, being the highest if it is bilateral ASWEL, followed by right side, and finally by left side ASWEL. And again, the main damaging factor was the intensity of the shock waves. Conclusion. We have a rather incomplete picture of the progression from acute injury to lasting damage, and how renal structure and function are affected, and the factors that influence the severity of the long-term effects.
Doctor, your time is up.
Still, the work that has been reported indicates actually that long-term effects are dose-dependent and can involve a permanent loss of functional renal mass, causing major disturbance to the patient. So the recommendations, how can we use this very, very intelligent technology to a more milder or a more gentle approach to treat these complications? First of all, we have to do our homework. We have to know whether there were previous episodes of stones, If yes, then can we know the nature of this stone? Can you analyze it? Can we do the 24 hours urinary studies? Can we detect exactly the size of the stone, if possible? And also the type of stone can be helped in some types of imaging like CT, low-dose CT, where we have different kind of opacities, denoting the possibility of the type of the stones. And once we know all these factors, the type and the site and the size, can we answer these questions? Are these cases with less chances of successful ESWL? And if yes, then we suggest not to do ESWL, even though it's less expensive and less invasive, but to go to endoscopic stone fragmentation, which is preferred, which is less in its side effects and more successful in the first-time procedure. And in cases with more chances of successful ESWL, well, it's better to do them with new and more advanced types of machines because they are usually using less energy to fragment the stones in these cases. And of course, as nephrologists, we should try to prevent the stone recurrence because it's a chronic disease, a multidisciplinary approach. This is staghorn stone found in the patient, and it was initially named the staghorn after this beautiful animal. And we are hoping as nephrologists to change the experience of stones to a beautiful one. And thank you.